Okay, I think we'll go ahead and get started. My name is Dr. Bill Walker, and I'm a pathologist that practices in Kalamazoo, Michigan. While we are beginning, I'd like to let you know that I can take questions during the presentation or afterwards, either by raising your hand or clicking on the chat function, and one of the HOSA assistants will let me know that there's a question, and then we'll take those as we go or afterwards. And I encourage you to ask any question you would like. So I've titled the presentation "Pathology on a Global Scale: What Does a Missionary Pathologist Do?" And a couple things I'd like to cover during our short time together would be, I'm going to let you know what a pathologist in practice does on a daily basis. I think a lot of people that are in the healthcare professions and medical school, whatnot, may not even have a good idea what a pathologist does. So we'll talk about that initially. And then we will go on to discuss how pathology can be utilized on the mission field, serving mission hospitals all around the world. And while my discussion will focus on how pathologists can be involved in medical missions, really a lot of what I will say will apply to any specialty in medicine, because there's a great need on the mission field for all of the specialties within medicine. So let's see here. So a little bit about my background. I did my undergraduate training in Milwaukee, Wisconsin, and then I stayed in Milwaukee for 4 years of medical school thereafter at the Medical College of Wisconsin. Did my pathology residency at the University of Iowa back in the mid-'80s, and at that time, the pathology residency was 5 years, and now, since about the late '90s, it's been reduced to 4 years, which is unusual that they would decrease the length of residency, but I think the residents that are finishing appreciate having 1 year less of training. I then stayed on at the University of Iowa for an additional year of fellowship training in cytopathology. And after that, I spent 4 years in the United States Air Force, and we can talk a little bit about that as we go. I had an Air Force scholarship to help pay for medical school. And then when I was done with all of my training, I paid back my 4-year commitment with the Air Force in Biloxi, Mississippi, down on the Gulf Coast. And it actually, for me, was a great way to pay for medical school. Back when I was in medical school, it was only, and I say only in quote marks, it was only $15,000 a year. Now with some medical schools being 50, 60, 70, 80,000 a year, scholarship opportunities like this through the Air Force or National Health Service or whatnot, I think is a great option for paying for medical school. I think it was a great option for me because when I finished with my Air Force commitment after 4 years, I had no debt when I started my practice in Kalamazoo, Michigan. I practiced at a large community-based hospital, about a 400-bed hospital in Kalamazoo. I practiced there for 25 years, and just last fall I retired from practice there, but I still continue on with a nonprofit organization that I started in 2007, and we will talk more about that as we go on. So pathology is defined in a couple of different ways. I've got a couple of definitions listed here. I think the most basic and most useful definition that I like is the second one, where it says it's the study of the origin, nature, and cause of diseases, as well as the diagnosis of disease. So it's I sort of think of it as an academic or a very intellectual specialty where you're doing a lot of investigative work trying to nail down specific diseases, whether they're benign or malignant. So we refer to textbooks an awful lot when we're looking at slides of particular unusual diseases and whatnot. So it's we've got a big library that we're using all the time to help us with our diagnoses. As I mentioned, the training for pathology and specifically involves medical school. Residency now is 4 years, as I mentioned. Many pathology residents opt to do additional fellowship training, either 1 or 2 years in a whole variety of subspecialties. And this is getting to be sort of the norm in many of the residencies today, many internal medicine, pediatrics, and whatnot. People tend to go on and do fellowship training in addition to the residency training that they've had. As I mentioned, the cost of all of this is incredibly expensive. Do keep in mind, though, that during your residency years and fellowship years, you are being paid. You're not making, a ton of money, but certainly you're making enough money to live on comfortably. So you're not racking up too much additional debt during residency and fellowship. And the one thing I like to stress with anybody that's considering medicine is I wouldn't get too bogged down with, the time commitment that's involved in getting trained or the debt. Keep in mind, you're going to be working till you're in your 60s, and some people are in their 70s, and you got to love what you do. And if you enjoy your specialty, this additional training, I don't think is a big factor. At least it wasn't for me. I finished my fellowship training when I was 31. So that still gave me, 30 plus years of practice. So even though you're a little bit older than some of your colleagues in high school and college and whatnot, before you're earning an income, if it's something that you enjoyed doing, I don't think it's a real drawback. And the debt obviously is something that you all will consider. And I have plenty of friends and partners that have been hundreds of thousands of dollars in debt. It can be paid off relatively quickly if you're focused once you're done with your training. So, and the scholarships, as I mentioned, can certainly help. So I personally wouldn't look at the time commitment or the finances to get trained as something that should sway you away from medicine. Pathology residency is typically divided into two parts, what's called anatomic pathology and clinical pathology. Anatomic pathology is that branch of pathology that focuses on looking at slides of tissues, either on living patients, surgical pathology, or autopsy pathology. So a couple of years of your training is spent doing that. And then clinical pathology is training which involves learning how to oversee and manage all of the different clinical laboratories, microbiology, hematology, blood bank, and whatnot. While those departments within the laboratory are really run and operated on a daily basis by medical technologists, they're doing essentially all of the work. You need to have a physician in charge of the laboratories in case issues, problems, questions come up. So pathology training has to teach us about all of those things. When it comes to the practice of pathology, especially if you get into private practice or community-based practice, almost all of the reimbursement that pathologists get in their income comes from anatomic pathology. Looking at slides of biopsies that the dermatologists send us, tissues that are resected by the surgeons. So that's where a vast majority of the income comes from. We still need to oversee the laboratory, but that's when it comes to payment and reimbursement from insurance companies and whatnot. Anatomic pathology is where the vast majority of our focus is. Autopsy pathology, many pathologists in private practice at community-based hospitals, many pathologists don't do autopsies anymore. They tend to be specialized now and they're done by the specialty trained autopsy pathologists that have done forensic training. And so they do a much more detailed and thorough job than private practice pathologists like myself. And so we have forensic pathologists in Kalamazoo, Michigan, that's all they do. And so if there are hospital deaths that need to be autopsied, they go to the group of forensic pathologists in town. Forensic pathology is, I believe, still a 2-year fellowship, and that's all they do. They just do autopsy pathology. They don't do any of these other things that I have here. So one of the main things that we do as pathologists is we handle any biopsies or resection specimens that come from the hospital, from the clinics, from the ORs. And then we have to look at these specimens and take sections of the specimens to look at under the microscope to make our diagnoses. So we handle everything that the surgeons take out of the body. This is just, I've got 4 or 5 slides here of representative things that we see all the time. And this is a kidney that's been taken out. It's been cut in half. And you can see normal kidney here in the background. This is what the normal kidney tissue looks like. There's some normal kidney tissue down here. But the rest of what you're seeing, all of this here, is a common kidney tumor called renal cell carcinoma. During our training, we are taught how these different tumors appear. This is a real typical appearance of renal cell carcinoma. It's so typical that an experienced pathologist can look at this, and just by the appearance of this tumor having yellow areas and sort of some gray areas and white areas, hemorrhage, small cysts here, it's very typical for renal cell carcinoma. We obviously take some sections to look at under the microscope to confirm the diagnosis. Other common kidney tumors have a totally different appearance. And so during the training and then your early years of practice, you begin to learn what all of these different tumors look like. Usually I have a ruler down here to sort of give a size reference, but these tumors can get very large. They can easily get the size of a softball or larger than that. And then we also learn how to sample these tumors to answer questions that need to be answered for the docs that will be taking care of these patients after the surgery. So surgeons will do the surgery and then follow up if they need chemotherapy or radiation therapy. Those specialists will need us to answer specific questions for them in our reports so they can advise the patients if any more treatment needs to be done after the surgery. So renal cell carcinoma is something that we see quite commonly. This is a section from a partial liver resection. So the normal liver tissue is what we see here. And large tumor here with a little satellite tumor here. And as I mentioned before, in all organ systems, tumors tend to have pretty characteristic appearances. When we're talking about liver tumors, those tumors that can get really large and have satellite nodules that have sort of this greenish discoloration. It's real typical for the most common primary liver tumor called hepatocellular carcinoma. The other name for it is hepatoma. And again, it's a really typical appearance of this kind of tumor. This pigment comes from the tumor cells actually making bile. The liver normally makes bile and is stored in the gallbladder and then secreted from the gallbladder. But even malignant cells such as hepatocellular carcinoma can form bile. And this green discoloration is really typical for this tumor. There are no other liver tumors that produce bile other than hepatocellular carcinoma. So a real typical appearance of this primary liver tumor. In the US, this tumor is seen almost exclusively in patients that are cirrhotic, most commonly from long-term drinking. But on a worldwide basis, probably the most common underlying condition of patients that have hepatocellular carcinoma is either hepatitis B or hepatitis C, really increases the risk for this tumor. So next we have This is the urinary bladder, which has been filled up and fixed with formaldehyde overnight to make it more rigid, and then it's been cut in half. So this is one half of the urinary bladder. This is the other half of the urinary bladder. And this is a very common bladder tumor called urothelial carcinoma. And it typically can get very large like this, and it has what's called papillary growth. So it has these finger-like processes or polypoid processes that grow into the bladder. So these patients usually present with blood in their urine because this tumor is eroding through the background mucosa and causing the patient to bleed in their urine. So then when you go in to see your urologist, they'll put a scope up into your bladder. They'll see this large tumor here. They'll take little biopsies, which are sent to us in pathology. And then depending on the kind of tumor and how advanced it is, sometimes they're offered surgery and sometimes they're offered other therapies, but they can take out the entire bladder like they did here. Then what they do is the ureters then are hooked up to the colon. And so no more urination takes place through the normal means. The urine then just drains into the colon. And so they reroute the ureters by doing that. Here is a lung, an entire lung, which has been resected. This patient has a form of lung cancer called squamous cell carcinoma. It's one of the very common, most common kinds of lung cancer. The background lung tissue is here. And all of this that you can see here is part of the tumor. It was so large and so advanced that they had to take out the entire lung. Sometimes they can take out 1 or 2 lobes or even a smaller portion of the lung tissue. But this was so large and advanced that they needed to take out the entire lung. People can survive just fine with just 1 lung. You're obviously not going to be a marathon runner or anything like that. But if you have a fairly sedentary lifestyle, you can do just fine with only 1 of your 2 lungs. Background here, you'll notice this is what really normal lung tissue looks like. You can see some black discoloration here, and that's either from this patient being a smoker or just somebody, a city dweller, inhaling pollutants for a long period of time. Our lungs can get black because of the pollution. If we see lung tissue from either a young person or somebody that lives out in the rural areas, a farmer or something like that, their lung will have virtually no black, what's called anthracotic pigment in it, but it'll look soft. It'll be soft and pink like we see here. So that gives you sort of an introduction to one part of what a pathologist does. And again, looking at these operative specimens, deciding how to sample them to look at under the microscope is a big part of what a pathologist does. I'll show you some of the microscopic examination in just a little bit. So now I wanted to segue now into how I got involved with medical missions and how pathology is necessary at mission hospitals around the world. I've been interested in medical missions for many decades. And first of all, I was a part of a short-term medical mission teams, one that went to Ukraine and China, and then Kenya multiple times, sort of showed me what missions and medical missions was like in the field. And since that time, I've become very involved in medical missions, giving conferences at multiple places around the world that you can see. And I've gone to several other places to help start up pathology laboratories. And just about 3 weeks ago, I was in Malawi in sort of South Central Africa, helping to set up a laboratory there. I want to give you a feeling for what medicine on the mission field is like, because for those of you that have never left the United States, you really have no idea what the practice of medicine is like in the developing world. We just sort of assume that hospitals and medical practice is like what we have here and in Europe, but it's not the case at all. This is a hospital that I've been to many times. It's about an hour and a half outside of Nairobi, Kenya. It's called Kajabi Hospital. It's a very typical mission hospital. This one is operated by the Africa Inland Church. That's what the AIC stands for here. This is just the main entrance to the hospital here in rural Kenya. Casualty is what they call the emergency room. So this is the emergency room, and you can see their very standard ambulance there on the right. Really, essentially, all that it is a Jeep that they can put a stretcher in. They have none of the things that our first responders have, no ventilators, nothing like that. This is essentially just a vehicle to transport a sick or injured patient to the hospital. This hospital has been around for several decades, so it looks sort of old, but that's sort of the typical scene of a missions hospital. This is inside the waiting room at Kajabi Hospital, and the way that things work at these hospitals is patients will line up first thing in the morning, wanting to be seen by a healthcare provider for a variety of ailments that they may have. And it's sort of done on a first come, first served basis. They're seen by a whole host of healthcare providers, not just physicians. Nurses will see these patients, physicians' assistants. So they're just triaged by a whole bunch of healthcare providers. Those that need to see docs will see physicians. Otherwise, if they have fairly minor ailments or something that can be handled by a non-physician, they certainly are addressed by those providers. One thing that I found sort of very refreshing when I was on the mission field is these people will line up first thing in the morning, and sometimes it may take them 6, 7, 8 hours to be seen because it's first come, first serve. It's a matter of how many healthcare providers are there to see these people. And these patients are incredibly understanding, they're patient, they're thankful just to be seen the day that they're there. You know, we've become somewhat spoiled here in the United States. I think we would all admit that. We have high expectations of our medical care, and rightfully so. We like to be seen quickly. We like to get all of the appropriate laboratories and X-ray studies done very quickly. And we want our medications, and we just want all of our issues addressed professionally, quickly, and we sort of expect perfection. And these people have much lower expectations, but they are so thankful for people that are willing to see them and care for them and treat them. So this is seen every day at essentially most mission hospitals around the world. This is a typical inpatient medical ward for children. This is one of the pediatric wards. One big room. Sometimes they have curtains that go in between the beds. Sometimes they don't. Families will bring in blankets to cover up the cots. Otherwise, you just lie on the cot. Families stay with their children. Families will sleep on the floor here or underneath their cot. Most of the time, the food that the patients get is brought in by their families. Families will provide a lot of the basic nursing care just because they don't have all of the other healthcare professionals that we do, therapists and nurses and nurses' aides and whatnot. They have a shortage. And so this is a typical ward, for a pediatrics ward. The adult wards look very similar to this. Here's one of the operating rooms at Kajabi Hospital. Typical operating room in the mission field looks like the operating rooms that I saw in Malawi just a month ago. Most of the equipment that is here has been donated from people or organizations either in the US or in Europe or in more developed countries, Australia, usually in fine working condition. You'll notice here that sterility is going to be an issue because they actually have a window here, and sometimes these windows are open to the outside. If the hospital here, if the electricity goes off, which it frequently does at these rural mission hospitals, generators will kick in to provide power to absolutely crucial things like the ventilator and whatnot, but lights will go out and they'll have battery-powered headlamps that the surgeons will put on, and they'll sometimes have to open the window to get some ventilation. If it's the middle of their summer and it's over 100 degrees, they'll sacrifice sterility for the cooling effects of some air from the outside, and that is just very typical in these mission hospitals. They're doing the best with what they've got. I want to show you some patients that were seen at the mission hospitals when I was there. And this condition, this patient just came to the mission hospital because he had no idea what was going on with his scalp here, which looks very interesting. It sort of looks like, for those of you that have seen the external surface of the brain, it really does look like what brain tissue looks like with the sulci and the gyri. But this is a totally benign and innocuous condition. It still is, they're not sure what causes this. This is not limited to just Africa or Southeast Asia, the developing countries. This condition is also seen in the US. It's very rare. What leads to the buildup of the soft tissue and the fatty tissue and these creases in the scalp, it's unknown. But what the healthcare providers at this hospital were able to tell him is it's nothing to worry about. It's not going to get progressive. It's just going to stay like this. It's not going to go away. Many of these patients will just wear a scarf or a hat to cover this up. But the patient was reassured that this is a rare condition, that he's going to be just fine. So now I've got several patients here that have extreme examples of different tumors, and this is really, really common in the mission field for patients to present with huge tumors. And the reason is they either live out in the bush far away from any medical care, so they can't get the care that they need. Most of them can't afford to go get treatment in a hospital. Many of these patients will have seen their local village witch doctor for months, if not years, without any effect on these tumors. And so eventually, these people make their way to mission hospitals to get seen and get treated. Obviously, advanced cases of these tumors, we just don't see here in the States because people go get their health issues addressed far earlier. So this young girl, I don't know if she's 8 or 9 years old, has had this tumor growing from her lower mandible. It started in the mandibular bone, and it's just been slowly growing outwards for years. And it's actually just sort of, this is a tooth that's embedded in it. It is just sort of pushed out as this tumor grew. Another tooth is here. The surgeon at the mission hospital here was able to resect this tumor, sent it to us in pathology. Totally benign tumor. But obviously this was getting in the way of this young girl being able to eat normally. Very disfiguring. And I'm certain that this young girl was ostracized in her village and community because of how she looked. People may have thought that she was possessed by demons, because why else would somebody get something that looks this crazy? But totally benign lesions. So once the surgeon addressed that, she went back to a normal life in her village and was accepted back as one of the villagers was. Totally benign tumor that had been neglected for years. This teenage woman was, I don't know if this was from the Kajabi Hospital or another hospital that I've seen and visited. She has this, it was actually a fairly rapidly growing tumor of her mandible. It's a very common tumor in sub-Saharan Africa. It's seen here in Africa much more than it is seen in the US. It's a form of lymphoma called Burkitt lymphoma. And mandible is just a very typical place that this tumor starts. It's a incredibly rapidly growing malignancy. Many of the missionary docs have seen multiple patients with this disease, and so they know how to recognize it. So what they typically will do is they'll make a clinical diagnosis. They have a couple basic chemotherapy agents that they can treat these patients with. So they will biopsy this tumor and send it off for diagnosis, but they can't wait, for the diagnosis to come back because it's such a rapidly growing tumor. They will start treating right away and either alter or stop their treatment if their clinical diagnosis is incorrect. But this tumor can double in size within a period of weeks, so they have to address this tumor very, very quickly. This little guy, I think when he presented, was about 3 years old. He was seen at a hospital in the South Pacific in Papua New Guinea and was cared for by a friend of mine that's an internal medicine doc. And he presented with this large tumor that actually started in the back of the nose, and it has been growing so long and neglected that it is now starting to grow out through the upper lip and through the nares here. So fairly large tumor, was biopsied. I looked at it under the microscope. It was a really bad malignant tumor that, if the patient were seen here in the US, he would get multiple chemotherapy agents as well as radiation therapy. In the medical mission setting in the developing world, they just don't have many options for young kids with this kind of tumor. This particular hospital had a couple chemotherapy agents that they were able to try, not the ideal chemotherapy agents that would be offered if he were here in the States. And certainly there was no radiation therapy available. So while this little guy ended up dying of his disease, the chemotherapy was able to give him about 2 to 3 additional years of pretty good quality of life. And so while the end result was sad, he was able to get some additional years with his family because they were able to give him some chemotherapy to slow the growth of this tumor. This is just another extreme example of the kind of patients that are seen at mission hospitals all the time. This woman has multiple tumors in her salivary glands, both within her cheek and neck, that I'm certain have just been growing for probably decades. And these tumors were biopsied. They're a common kind of salivary tumor that's benign. So benign, slow growing, not going to metastasize and spread throughout her body. But even though it's benign, you can tell it's obviously causing her great issues, primarily with nutrition And given time, this would probably start to cause respiratory issues for her also. So what was offered to her was surgery to remove these tumors, sort of done in a staged procedure. It would be too much to handle for her in one sitting. So one surgery probably took off this tumor, and after that was healed, she would come back for maybe resection of this tumor. And so in a staged procedure, over a period of probably 6 to 9 months, they were able to remove these benign tumors and get her back to a pretty normal lifestyle. I'm sure she was able to eat and drink and breathe just fine. With obviously she'll have some scars, but this, instead of killing her, which it would have given time if she weren't addressed at the hospital, they were able to give her some quality care. So I set up a nonprofit organization to provide services for these mission hospitals back in 2007. Organization is called International Pathology Services. And through my short-term trips to the mission field, I saw that there was a big need for pathology services at these mission hospitals. And most of these mission hospitals just have a very small laboratory that is there to run blood tests. They don't have enough trained in-country pathologists to staff these hospitals. And most of the hospitals are quite small, so one pathologist wouldn't keep busy at most of these hospitals. So there's this pathology need out there that I saw was not being addressed. So the surgeons at these mission hospitals, they see these patients and they can operate on these patients. But even if they do, they don't know if these tumors are benign or malignant. And will one surgery be enough, or do they need to do additional surgery? If it's malignant, if it's cancerous, some of these mission hospitals, especially if they're close to the capital city, the patients can be offered chemotherapy if they can afford it. And on the flip side, the surgeons at the mission hospitals, in addition to having a medical focus caring for their patients, they want to address spiritual needs of the patients. And so if they can tell their patient that this is whatever kind of malignancy it is, and the typical lifespan of the patient will be 3 or 6 months, then they can share that with the family, with the patient, and then they can focus on spiritual needs of the patients rather than putting them through additional surgery and having them spend money on chemotherapy that's just not going to do anything. So while my organization, International Pathology Services, provides services to Christian mission hospitals around the world, these mission hospitals, even though they're staffed by Christians, they provide medical care for people of all faiths. So whether you're Jewish or Hindu or Buddhist or whatnot, all patients are welcome at these hospitals, and the same care is given no matter what the faith of the patient is. So the docs want to be able to remove what the abnormality is. They want to get a correct diagnosis. If they don't have pathology available, then they're left with their best clinical judgment based on their personal experience and, what liver tumor, for example, is most common in their particular country. And many of these missionary surgeons are very, very sharp clinicians, and having seen many of these things for years, oftentimes their diagnoses are spot on, but they too would like to know what the most accurate diagnosis is. Now, there are some options in the mission field. You can send the specimen to a government hospital in the capital city. Problem with that is the patients or their families have to transport the specimen there. That can be difficult. It can be very expensive. The turnaround time to get a report can be very, very long because those hospitals are very understaffed. So, and the quality of the diagnoses oftentimes is not good whatsoever. So, International Pathology Services, we look at biopsies, surgical resections, cytology specimens, all sorts of specimens from these mission hospitals. Most of the specimens come back to the United States with people that are traveling back to the States. So these hospitals will accumulate these specimens in little jars. The tissue is fixed, so it's not infectious. And then when any traveler is coming back to the States from the mission field, they don't need to be a doc. They could be a family member that's visiting somebody over at the mission hospital. Anytime somebody's coming back, they can put some of these specimens in their checked baggage and then ship them to us once they get back in the United States, either through the Postal Service, FedEx, or UPS. We look at specimens, myself and my partner in this nonprofit organization. We look at mission hospital specimens from 34 different countries all around the world. I've got this map in my office, now in my home, of each of these pins is a location of a mission hospital that we get specimens from. Little specimens are fixed in formalin, put in these little containers and shipped to us. This is a requisition form that the local doc has filled out, giving us a little history of what kind of specimen we have. This was an ovarian mass in a young pregnant woman that they sent us. We take little sections of the tissue, slides are made, and this is what we look at under the microscope. And we generate a report like this that is sent electronically through our website to all of the mission hospitals around the world. This doc is a physician that practices in Papua New Guinea, and so they get the copy of the report back, and then they, it may take a couple weeks, but by then they can call the patient back and discuss the findings. So I'll leave it some time here for questions that you all may have. So there's a great need for all specialties within the mission field. There's a need for everything, whether you go into radiology, pediatrics, OBGYN. You don't need to be a doc. You can be an ultrasound tech. You can be an occupational therapist, a physical therapist. You can be an optician. All of these healthcare fields, there's a great need for people both on the field or doing things at a distance, like I'm doing with International Pathology Services. So if you don't have time to ask a question, if you have any questions about medicine, pathology, my military scholarship that I had to get me through medical school, I'd be glad to talk with any of you through email. My email address is there. So rifle off any questions that you may have for me, or you can raise your hand now or through the chat. The HOSA representative will help me answer those. And I thank you for joining in with me today.
Yeah, I'll start out with a question. Thank you for this presentation. I think it really opened my eyes to some of the disparities that are definitely in healthcare in developing countries. But how would you say those mission hospitals are financed, and is it ultimately sustainable if it's just off of like charitable donations?
Good question. The hospitals are run on, there are multiple different ways of funding. So it's donations, individual donations. corporations, nonprofits around the world. The governments also are supporting these hospitals. So there are multiple sources of funding, both for the institution as well as the people that are there working in the hospitals. Most of the missionary healthcare providers that are there are supported by donations from friends, family, and whatnot back home. So their salaries are taken care of. They raise their own support. They aren't paid by the actual country. And so, yeah, the docs and whoever are responsible to raise their yearly support that they need.
Alrighty, I see another great question in this chat, but I'm so sorry, we're gonna have to end this session. But Kirsten, if you can just take down Bill's email and send that email over to him, I'm sure he'd be happy to answer that question for you. So sorry, I'm gonna have to end this session now so we can start this next session, but thank you all for being here today. And thank you so much, Dr. Walker, for sharing your knowledge with us today.
Yeah, you're very welcome. And please do send your emails. I will be online all afternoon. Thanks a lot.
No, Carrie wasn't on my list because she wasn't on my list because Jen ordered all